Good evening, all. We welcome you all to the AFPI National Clinical Meet Series for the month of July, which is being hosted by AFPI Kerala chapter. So today we have a pediatric case presentation pertaining to nephrology topic. The case will be presented by Dr. Bismita. She is the first-year family medicine resident at KIMS Health Trivandrum. And we have two moderators for today. Our chief moderator will be Dr. Prijo Philip. He is the consultant pediatric nephrology at KIMS Health Trivandrum. We have been a part of AFP academics for quite some time, last 2-3 years. Welcome you, sir, for this. And our second moderator will be Dr. Aishwarya Nambudri. She is a family medicine specialist at KIMS Health Trivandrum. Over to the moderators and the presenter.
Shall we start? Shall we start then?
Yes, sir.
Yeah, okay.
Good afternoon, all.
Just 1 minute, please. Kindly requesting all the participants to keep your mics on mute when the presentation is going on as a part of the ticket of the meeting.
Good afternoon to all. Am I audible?
Yes, you are audible.
So, respected teachers and my dear friends, here I am going to present the case of nephrotic syndrome. Presenting a case of Adoni, 4-year-old girl hailing from Nagarkoil, Tamil Nadu. Her informant is mother. History is reliable. She is the first child of non-consanguineous marriage. Date of examination is 27 July 2024. She is presented with complaints of fever 3 weeks back, cough 3 weeks back, earache 3 weeks back, and it was treated, now came for the review. History of present illness. Child was a non-case of nephrotic syndrome under follow-up, developed fever, which was low-grade, continuous, and associated with running nose and earache. No history of any discharge or decreased hearing. Fever subsided in a day on giving paracetamol. Then no history of dysuria or vomiting or loose stools, no history of any headache, no history of cough or fast breathing, no history of joint pain, no history of reduced frequency and quantity of urination and frothy urine, no history of any swelling in the lower limb, no history of discoloration of urine or painful urination, no history of abdominal pain, abdominal distension, joint pain, skin rashes, no history of any loose stools or vomiting, no history of breathing difficulty, no history of any jaundice, any bleeding manifestation, no history of insect bite, drug injections or itching of the skin, no history of altered sensorium, headache, or seizures. And since she consulted the KIMS and her lab results showed abnormal values, she was started on steroids, took steroid for 3 weeks, and now came for review. Past history. She had history of puffiness of the face, swelling of the lower limb, and decreased urine output following 3 to 4 days for fever after a low-grade intermittent fever and rhinitis on September 2021. She was diagnosed to have nephrotic syndrome and was admitted and treated at KIMS. She responded well. She was started on prednisolone 2 milligram per kilogram per day and followed up and was doing well. And the relapse is over so far. On October 2021, that is after 1 month after the first episode, she had, while on daily dose of steroids, she had an infection-induced relapses and she was treated as per the protocol and attained remission. And next relapse was on next month, that is December 2021, while on alternate days of steroids, 15 mg dose due to upper respiratory tract infection. It was also treated and attained remission. On January 2022, next relapse occurred and it was infection-induced because of the acute gastroenteritis. It was also during the alternate day dosing. Because of this frequent relapses, because of the frequent relapses, cyclophosphamide was started on February 15, 2022, and it was completed on April 30, 2022. Levomethosone was also started on May 2022. She was off, she responded well and attained remission, and she was off steroids on May 2022. And after post cyclophosphamide, that is almost after 1 year, she had her first relapses on April 2023, and it was also treated as per the protocol. And post cyclophosphamide, second relapse occurred 6 months after this. It was also infection induced. By the time levomethosone was stopped at December 2023. Post cyclophosphamide third relapse occurred on June 2024. It also attained remission. Post cyclophosphamide fourth relapse occurred in this month, that is July, because and it was the current relapse, which is minor one. There was a history of hospitalization 2 times in the past during the relapses, and no history of any other hospitalization, no history of any tuberculosis or heart disease or liver disease, HIV, hepatitis B. Antenatal, natal and postnatal history. She was a first child of non-consanguineous marriage. She was conception after 3 years of marriage, post-ovulation induction. Antenatal period was uneventful. Regular antenatal checkup done. Took iron, calcium, and folic acid. Tetanus 2 doses taken. No drug or radiation exposure. No history of GDM, hypertension, or UTA. Scan done in all trimesters, and they were normal. She born by elective LSCS at 38 weeks, which was family opted, and her birth weight was 3.300 kg, and cried soon after the birth. Urine and meconium passed within 24 hours. No history of any NICU admission. Developmental history, developmental milestone attained up to the age. Grows, hopes on the food, fine. Copies the throws. Language, says poems. Social, dresses and undresses. Diet history, she exclusively breastfed till 6 months of age. Complementary feeding started with ragi at 7 months. Started sharing family diet at 1 year of age. No history of any food allergy. Child is getting 1640 kilocalorie and 24 gram of protein per day according to 24-hour recall method. And she is expected calorie is 1360 kilocalorie and 16 gram of protein according to the ICMR. Excess of 280 kilocalorie and excess of 8 gram of protein. Immunization history, she immunized fully up to the age according to the national immunization schedule. Optional vaccines taken, pneumococcal vaccine taken, and PPSV 23 given. 2 doses of influenza vaccine was given. BCG scar is present on the left upper arm. No history of any severe adverse vaccine reactions. Family history. First child of non-consanguineous marriage. No history of a nephrotic syndrome in the family. Younger sibling is 1.5-year-old girl, and no history of any other significant illness in the family. Socioeconomic history. Father is in abroad. Mother is a homemaker. According to the modified Kuppaswamy scale, belong to upper middle class family, living in a pakka house with good ventilation and sanitation. Drinking water is from tap water from panchayat, and no overcrowding. Summary: 4-year-old developmentally normal child, immunized for age, with history of nephrotic syndrome, diagnosed at 1 year of age, with recurrent relapses, post cyclophosphamide with good responses, that is 1 year of remission before the next relapses, and post levomethosone, now on steroids, with recent history of fever and rhinitis 3 weeks back, and on evaluation presented with altered lab values and came for review. General examination. Child is alert, active, moderately built and nourished, no pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. Vitals: pulse rate is 100 per minute, normal rhythm, volume, character, no radial or radiofemoral delay. All peripheral pulses felt equally and bilaterally. BP is 100/70 mmHg, upper limb in the supine position. Respiratory rate is abdominothoracic. SpO2 is 98% in the room air, and temperature is 98.5 degree Fahrenheit, and CRT is less than 2 seconds. Head to foot examination. Head is normal, no facial dysmorphism, no malar rashes. Eyes, ears, nose and normal. Oral mucosa and throat is normal. Neck is normal. BCG scar is present on the left upper arm. Chest normal. Abdomen is normal. No edema on the lower limbs. No joint swelling or deformity. Skin appears to be normal. No rashes or pyoderma. Nails normal. Spine normal, and genitalia is normal. Anthropometry. Weight is 17.8 kg, between 15th at 50th centile. Height is 105 centimeter between 15th and 50th centile. Weight for age is above 50th centile according to WHO growth chart. Mid upper arm circumference is 17 centimeter. Body surface area is 0.72 meter square. Systemic examination, gastrointestinal system, upper GI tract, oral cavity is normal. Abdominal examination, inspection shape is normal. Umbilicus is central and inverted. Flanks are free. Skin normal. All quadrants move equally with respiration. No visible pulsations or peristalsis or dilated veins. Palpation, no local rise of temperature or tenderness. Liver is palpable 2 centimeter below the costal margin. Smooth round border. Liver span is normal. Spleen not palpable. Abdominal girth is 43 centimeter. No other mass palpable. Percussion, resonant note obtained. No shifting dullness or fluid thrill. Auscultation, bowel sounds heard 3 per minute. No abdomen or renal bruit. Hernial orifice looks normal. External genitalia is normal and no swelling is noted. Other system examination, respiratory system, upper respiratory tract is normal. Normal vesicular breath sounds heard in all areas. No adventitious sounds. Cardiovascular system, first and second heart sound heard normally. No added sounds. CNS alert. No focal neurological deficits. Summary. 4-year-old developmentally normal child, immunized for age with history of nephrotic syndrome, diagnosed at 1 year of age with recurrent relapses post cyclophosphamide, good response at 1 year of remission, and post levomazole non-steroids with recent history of fever and rhinitis. 3 weeks back on evaluation, presented with altered lab values, came for review. On examination, she is active, vitals are stable without any edema, and height and weight is above 3rd centile, and systemic examination within normal limits. Diagnosis, nephrotic syndrome, post cyclophosphamide on remission, or probably high-dose steroid dependent without complication and no atypical features. Fully immunized up to age, no adequate nutrition, developmentally normal.
Thank you,
Okay.
Dr. Bismita.
Okay, ma'am.
That was a good case presentation. Dr. Priju?
Yeah, I'm here. Okay, so I want to ask a few questions. So you said there are no atypical features. So what are the atypical features that you are talking about?
Patient with
Hello?
hello, sir.
Yeah, what are the atypical features during presentation of a nephrotic syndrome? So see, this is a known case of
Okay.
nephrotic syndrome. So it's
Yes,
easy. So it's easy to say that this is the nephrotic syndrome. But ideally, when we present the case for the first time, so because we already know the history, this is not needed. But the most important aspects of this history is the age of onset of symptoms. That is, at what age did the symptoms present? I think in this child presented at about 1.5 years of age.
1 year.
This is important.
Yes.
This is important because if the child is presented for symptoms less than 1 year of age, it becomes an infantile nephrotic syndrome. If it becomes less than 6 months of age, it becomes a congenital nephrotic syndrome. So that is very important in order to give the prognosis. So that is also one atypical feature, actually. The other atypical features are if the child presents with, now most of the nephrotic syndromes, at least 20 to 30% of cases do present with what we call as microscopic hematuria. So microscopic hematuria means when we look through the microscope, you can find hematuria. But there is an atypical feature sometimes, but this has to be noted, that is there. Sometimes the child can present with gross hematuria, that is cola colored urine. Okay. So previously it used to be called as nephritic pattern. So that is an atypical feature. If the child presents with gross hematuria, that is an atypical feature. And then if the child presents with any increase in renal function, okay. So now if this child is 1.5 years, am I audible?
Yes, sir.
Yeah. So if this child is a 1.5 years old child, her normal expected creat would be somewhere along the range of 0.2 to 0.3. Now, if this child is presenting with an initial creat of 0.6, 0.7, let's say, that means the child is presenting with an acute kidney injury, which makes it an atypical feature, which again, that is an atypical feature. The other atypical features are, you've already mentioned in your history, but I'm not sure whether you know. So you've asked for history of rash and joint pain. So why have you asked that?
Yes, because it can associated with other conditions like connective tissue diseases syndrome.
Okay. So now, while that is common, that is a good answer if the child is an older child. In younger children, the diagnosis of connective tissue disorders is unlikely. But yeah, if this child is presenting in an older age, maybe 7, 8, or even in the adolescence above 10 years of age, we must remember connective tissue disorders, especially lupus. Okay, SLE can present because SLE has got a tendency to present both as a nephritic pattern. That is, it can present as a glomerulonephritis. It can also present as a nephrotic pattern. Okay, or both. The other differential diagnosis is IgA vasculitis and HSP nephritis. Now, actually, collectively, it is called as IgA vasculitis. Previously, it used to be separately called as IgA nephropathy and HSP nephritis. Yeah, henoch-Schönlein purpura. Currently, the broad category is IgA vasculitis. So these conditions can present with bone pain, joint pain, rash, especially lower limb rash, the rashes which are more in the thighs. So that in that case, this history becomes important. Okay. The other conditions are ANA and ANCA vasculitis. So in an older child, all these things must also be noted. So all of these are atypical features. Okay. I would refine the diagnosis. I'll go bit by bit. I will refine the current up to now the diagnosis as a nephrotic syndrome, and with the onset of symptoms at 1.5 years of age, with no atypical features at onset of presentation. Okay. So up to now, let's hold it. Now my question is, what is the normal urine protein excretion for a child?
Less than 0.2.
That is urine PC ratio. So what is nephrotic range proteinuria?
Nephrotic range proteinuria is defined as protein, urine protein more than 3.5 gram per 24 hours. Then hypoalbuminemia, that is less than 2.5 gram per deciliter, and edema associated with hyperlipidemia.
See, that is actually an older definition. So right now, the definition is urine dipstick 3+ or more on 3 consecutive days, or a urine PC ratio of more than 0.2 with hypoalbuminemia, which, as you said, edema of, the albumin of less than 2.5, with hypercholesterolemia, that is cholesterol levels of beyond 200, with or without edema. So that means you don't have to diagnose, the diagnosis of nephrotic syndrome need not be with edema. Okay. Even without edema, a diagnosis of nephrotic syndrome can be made. The important thing to note here is that there are 3 categorizations of the protein excretion. One is normal urine protein excretion, which means urine protein creat ratio is less than 0.2. There is a nephrotic range of protein excretion, which is more than 2. There is urine PC ratio of more than 2. And then there is a non-nephrotic range proteinuria. That is, it is significant, but it is not in the nephrotic range. Okay. So that is between 0.2 to 2. Am I clear?
Okay, sir.
Okay. So many of your PSGNs, post-infectious glomerulonephritis or post-streptococcal glomerulonephritis, will have proteinuria in this range, between 0.2 to 2. Okay, so they are called as non-nephrotic range, but significant proteinuria. Okay. Yeah. So now that you know the diagnosis of nephrotic syndrome, so what are the types broadly based on treatment regimen? What are the types of classification? I'll just deal with the important questions that can be asked if a case is asked during exam. So what are the important classifications of nephrotic syndrome based on treatment or based on response to treatment?
Steroid resistant, steroid sensitive nephrotic syndrome, steroid resistant nephrotic syndrome.
Yeah. So broadly, we classify it into steroid sensitive. So we know that I won't go into that. The treatment for nephrotic syndrome is steroids, right? Now,
Yes,
what is the normal treatment duration?
Initial treatment, you will be full dose of steroids of 2 milligram per kilogram per day for the 6 weeks, which can be tapered into alternate day of 1 milligram per kilogram per day, and then we'll see the response.
No, that's wrong. It is not like that. See, the treatment is we have to remember the treatment is 60 milligram per meter square per day. So you said the meters, the body surface area is 0.7 something.
0.72.
So yeah, 0.72. So based on that body surface area, and I'll tell you why we have to classify in this case as body surface area. So in this case, it will be 60 mg per meter square per day or 2 mg per kg per day daily for 6 weeks. And if the child has attained remission, followed by 40 mg per meter square per day or 1.5, it's not 1.5 mg per kg per day on alternate days, given as a single or a divided dose for another period of 6 weeks. Okay. So the initial dose is 60 milligram per meter squared daily or 2 mg per kg per day for 6 weeks, followed by 40 mg per meter squared per day or 1.5 mg per kg per day on alternate days. That is, but you can only give that once the patient has attained remission within 6 weeks. Okay, because if the patient has not attained remission within 6 weeks, then there is no point in going into the alternate day regimen. Understand?
Yes, yes.
Sir,
Okay.
sir, excuse me, sir. Sir,
Yeah.
Sir, can you explain a bit more slowly? Somebody
Okay.
has raised a concern.
Okay, so see the dose regimen, I'll just go through the question. Yeah. So the dose regimen for first episode steroid sensitive nephrotic syndrome, suspected steroid sensitive nephrotic syndrome is 2 mg per kg per day or 60 milligram per meter squared. Okay. Now I'll give you an example in the sense that now this child is let's say this child was if I remember correctly, let's assume that this child is about I think she said 14 kgs. So if you go as 2 mg per kg, the dose will be 28 mg, which will be rounded off to approximately 30 mg. Correct?
Yes, sir.
Correct? Yeah. Now, if we go by body surface area, then you can calculate 60 mg per meter square. That is 60 into 0.72. And you will get the dose as 43 mg. Okay? Correct? If you have a calculator in your hand, you can very well calculate. Your child's weight is 14 kgs. If you calculate as 2 mg per kg per day, the dose comes to 28. You can round it to 30 mg. If you take the dose as 60 mg per meter square per day, the dose comes to 60 into 0.72, which is 43 mg. Okay.
Yes, sir.
Now, now you can understand there is a difference of approximately 15 mg in the dose. So we, in smaller children, we prefer to go by body surface area rather than mg per kg. And that is why it is important to know both the definitions. In smaller children, if you go by mg per kg, because their body surface area will always be high. So if you go by mg per kg alone, you may end up giving lower dose of the medicine. So in a smaller child, it is always preferred to go for a the mg per meter square dose. That is, you calculate the meter squared and then you give the dose. Why this is important is, if the child does not respond initially to a 2 mg per kg dose, you will always have a doubt in your mind that if I had given a higher dose of medicine, would the response have been present or not? Correct?
Yes.
Because if you calculate as a milligram per meter square dose, you would get a higher dose. So maybe the child would have responded to that. Then ultimately, the physician would end up giving a second dose in a higher dose format, and you would add to the steroid toxicity and the adverse side effects. So my advice would be, then this is not given in any textbook, but always when you're faced with a smaller child, try going for a body surface area dose. So if you don't know how to calculate the body surface area, I will tell it now, and I will tell it slowly. It is, hello, am I audible?
Yes, sir.
Yeah.
Yes, sir.
It is the height in meters. Hello, Bismita, how did you calculate
sir,
the body
yes.
surface area?
Sir, height.
Height into?
One
It is height.
point.
It is height in meters into weight divided by 3,600. And you have to take the whole square root of this. So it is called as the Mostelli's equation. Okay, Mosteller's equation. That you don't need to remember the name, but it is height into weight divided by 3,600, the whole square root. Okay, so that will give you the body surface area, and with that body surface area, you can give the correct dose. Okay. Now, when the patient initially presents with a case of nephrotic syndrome, the treatment would be, as I said, 6 weeks of daily steroids. And if the child has attained remission, you switch it over to 6 weeks of alternate day steroids. Now, there is a reason why we give 6 weeks. You don't have to remember this. Nobody is going to ask you this, but I'm just telling you for your knowledge. Usually, when we start the dose of steroids for nephrotic syndrome patients, the literature says that at least 75 to 80% patients respond in the first 3 weeks. Between 80 to 85% patients respond within 4 weeks. and at least 90 to 95% patients will completely respond by 6 weeks. So that is the idea behind us giving the dose of steroids up to 6 weeks. Okay, there is a rationale behind that because literature evidence has proved that 90 to 95% patients, that is, there is a last that last bit of 10 to 15% of children who can only respond to steroids if you give it over a period of 6 weeks. So that is why the dictum is that we give it for a period of 6 weeks. Okay. So once we give steroids for 6 weeks, once we and we do the urine test, and if we make sure the urine albumin is negative, that means the child is in remission, and then we switch on to the alternate day regimen. That is 40 mg per meter square dose or 1.5 mg per kg per day on alternate days, and that you give it for another 6 weeks. Okay.
Okay, sir.
Yeah. Now there is a catch-22 with this situation. There are some books that say you can stop directly the course of steroids after 6 weeks. There are some books and guidelines which say taper and stop. Okay. Now the Nelson textbook of pediatrics doesn't say how you taper and stop. Generally, what we do is we taper by 5 milligram to 10 milligram every week, slowly, and within a period of about 1 month, we'll come and taper the dose of steroids. Okay.
Yes, sir.
It's clear, no? It's not very difficult.
Yes.
Okay. Now, so that is steroid sensitive nephrotic syndrome. So what is steroid resistant nephrotic syndrome?
Steroid resistant nephrotic syndrome means even after the treatment. Hello.
Yeah.
Hello. It is a failure to achieve the remission after 6 weeks of corticosteroid therapy.
Yeah. Important thing here is, and which many books will not say, and many nephrologists or teachers will not say, is that failure to gain remission after 6 weeks of daily steroids, after making sure that the dose is correct, and this is why the importance of what I said previously, calculation by milligram per meter squared, after making sure the child has received an adequate dose of steroids and the compliance is good. This is very important. Now, if you write the child needs 45 mg of steroids daily, but they are not taking it daily. Okay. They are not taking it daily, and if they're taking it alternate day, the compliance of medication is poor. You cannot label the patient as steroid resistance, can you? That means the compliance is only poor. Hello?
No.
Yeah. So
Yes,
if the
sir.
patient has, once you make sure the compliance is right, the dose is correct, and still after 6 weeks, the patient has not attained remission, that is called as steroid resistance. Okay. Clear, no?
With proper complaints, yes.
Yeah. So now now you have steroid sensitive nephrotic syndrome and steroid resistant nephrotic syndrome. Under steroid sensitive nephrotic syndrome, you have a certain few classifications. What are they?
Remission.
No. Remission we already classified.
Relapses, steroid relapses.
So steroid relapses means
recurrent relapses, that is urine dipstick more than 3 plus and your PC ratio more than 2 on 3 consecutive days during an infection.
No, that is the meaning of a relapse. You're defining a relapse, but there are different kinds of relapses, no?
Frequent and infrequent relapses.
Yeah. So what is a frequent relapse?
Frequent relapses means actually
a frequent relapser is a person is a child who relapses more than 2 times in the first 6 months following getting treatment. Okay. Now, for example, my onset of nephrotic syndrome, if I, for example, I have nephrotic syndrome in January, my treatment got over in April. Within 6 months of my finishing getting treatment, so April to May, June, July, August, September, October. So within a period of October, if I get 2 relapses, I become a frequent relapser, or I should have more than three relapses in a 12-year period. So it is more than 2 relapses in a 6-month period, or more than 3 relapses in a 12-month period. Okay. And whatever is not a frequent relapser is an infrequent relapser. That means less than 2 relapses in 6 months, obviously. Okay. Now there is a third type called steroid dependent. So what is steroid dependent nephrotic syndrome?
Steroid dependent nephrotic syndrome means during the remission occurs only after after within completing steroid
You
after
have to understand
2 weeks,
the
2 weeks.
no. You have to understand the difference between a relapse and remission. Remission means the urine protein is becoming negative.
Oh.
That is remission. Remit means the protein becomes negative on 3 consecutive days. A relapse means the disease has come again. So the definition of steroid dependent nephrotic.
Relapse occurring within 2 weeks of completing steroid therapy, or during an alternate during switching from daily to the alternate therapy.
Yeah. So it means that when you switch over from a daily, so I've already told you that after 6 weeks of daily steroids, you will switch over to an alternate day regimen, right? Of 40 mg per meter squared. So if a child relapses when you have reduced this dose to an alternate day regimen, within 2 weeks of reducing the dose to an alternate day regimen, or within 2 weeks of stopping the dose of steroids, it is called a steroid dependent. But that's not the whole definition. Okay. The whole definition is if the child has developed 2 or more relapses. That is the important number. More than 2 or more number of relapses after when you are tapering the dose of steroids to alternate day or on stopping steroids. That is called a steroid dependent nephrotic syndrome. Okay, so you need to have 2 or more relapses, 2 or more dependent relapses before you classify the patient as steroid dependent. Now this is very important. Why? Because at least while majority of the nephrotic syndrome children, that is at least 80 to 90% of children are steroid sensitive. Among these steroid sensitive children, only 10 to 15% of children are infrequent relapses. That is, they may never relapse again. Okay, 30% of children go on to be frequent relapsing nephrotic syndromes, and 30% children go on to become steroid dependent nephrotic syndromes. And at least 10% of children go on to become steroid resistant nephrotic syndromes. Okay.
Okay, sir.
Okay. So what is late steroid resistance?
After 1 year of remission.
No. So a late steroid resistance is a child who was initially steroid sensitive. Okay, that is initially steroid sensitive and responded to steroids, but later on goes on to become a steroid resistant nephrotic syndrome. So that can always happen. Okay, you can have a steroid resistant nephrotic syndrome who was not treated well and becomes worse. You can have a steroid resistant nephrotic syndrome who underwent treatment properly and became steroid sensitive. You can also have a steroid sensitive nephrotic syndrome who, if not treated properly, can become steroid resistant. Okay. So the pattern can always change, and that is why it is important to remember a patient who is a patient who is initially steroid sensitive can later on become steroid resistant. That is called late steroid resistance. Okay.
Okay, sir.
Okay. Now, what are the so we know that this is a nephrotic syndrome. We know that what are the types of nephrotic syndrome that I told you: steroid sensitive, steroid resistance. The steroid sensitive nephrotic syndrome is divided into steroid frequent relapsing nephrotic syndrome, infrequent relapsing nephrotic syndrome, and your steroid dependent nephrotic syndrome. Okay. Now, so I also told you the initial treatment is with steroids. Now, so when the patient is getting steroids, what are the complications that you have to expect to tell the patient?
Patient can have weight gain, then recurrent infections, and during immunocompromised condition will be there, so we cannot give live vaccines. Then mainly recurrent infections.
No, actually, apart from that, there are a lot of other complications. There are a lot of practical complications which people don't explain. One is steroid causes an increased appetite. Okay. So many parents will become worried because the child will have an increased appetite. Those who eat probably, so we commonly get in the OPD, children who eat maybe 1 idli, 2 idlis will suddenly be eating 4 or 5 idlis, and they'll demand feeds every 4 or 5 hours. 2-3 hours also I've seen. So increased appetite is one. Okay. Hyperactiveness and agitatedness is another. So I've had a couple of children who have been reported by their parents who start abusing their parents, and they'll be very small children, 3 years, 4-year-old children who will start abusing their parents. So hyperactiveness, agitation is one. Behavioral disturbances. These are very common complications. More chance of infection. That is true because they are already in an immunocompromised state. That is true. Other complications are long-term complications like steroid-induced hypertension, steroid-induced osteopenia because it affects the osteoclasts. and therefore it affects bone formation. So in the long term, it can cause short stature, and it can also cause steroid-induced diabetes mellitus. Okay, all these are important for patients who are receiving steroids for a longer term. So in fact, I've had also patients who come who report to the OPD, who after years they will understand that the treatment for nephrotic syndrome is steroids, so they will act smart. They will give steroids on their own, and then ultimately they will come with severe vertebral fracture. So those and all are irreparable. Once the vertebra is fractured and all, it's irreparable. So these are common complications that we have to explain to the patient. So the bone disturbances, osteopenia, the issue with respect to diabetes, the issue with respect to hypertension, these must also be explained to the patient, along with the chance of higher risk of infection. Okay.
Yes, sir.
Okay. So what are the common complications of nephrotic syndrome?
Patient can have edema, fluid overload conditions.
Okay.
Then decreased urine output can occur.
That is one of the reasons for the edema.
Then it can produce a kidney injury, acute kidney injury. And basically fluid overload, then it can increases the hypercholesterolemia, increases the cholesterol.
But
So it
will
can
that cause
produces
any? But will that cause any complications?
Yeah, it can produces acute heart issue, cardiovascular complications can occur.
No, never. Then for all these patients, we'll be starting on atorvastatin. No, there is no proven evidence that hypercholesterolemia will cause heart-related complications for children, except in those cases who are having SLE, lupus. Okay. So one of the complications of steroids, which I did not explain, is hyperlipidemia. Okay. So many of these patients, when they recover, when they're getting the dose of steroids, they will already have hypercholesterolemia. So what is the reason for hypercholesterolemia in these patients?
It is because proteinuria, it can produce, because of the increased albumin is going through the urine, it can produces a reflex increase in the production of the cholesterol.
So basically put, where our body, when we lose protein, we are losing albumin, but the body is detecting that it has lost a large amount of protein. Okay. So the body's protein factory, or the body's where the protein is synthesized, is in the liver. So the body's automatic message goes to the liver and says, we need a large number of proteins to balance this. So the body keeps producing large amount of proteins. So among these proteins, there are vitamin D transporting proteins, proteins which are responsible for thyroid metabolism. And that is why in most of these patients, you will find hypovitaminosis D, you will find hypothyroidism, because everything will be deranged in these kind of patients. So one of the proteins that is accidentally elevatedly produced is cholesterol. So that's how you find hypercholesterolemia in these kind of patients. Now add to that, these patients also receive steroids. So when they receive steroids, that also as I said, the steroids also cause a complication of hyperlipidemia. Okay. So when you say the complications of nephrotic syndrome, I can see that some people have replied on the group, so it's correct. So one is it can cause infection. So one is obviously infections because you're already losing a lot of important immunoglobulins and proteins along with the albumin, so that precludes you from having a high chance of infections. Second, you're also getting steroids. That increases your chance of getting infections. Third is as somebody said, acute kidney injury is an important complication, because very often these conditions can be precipitated by an inciting event like diarrhea, so whatever, that can cause an acute kidney injury. Fourth of all, it can cause thrombotic complications, because part of an acute kidney injury, because the body will lose water, and there is a mismatch between the body trying to preserve water and the body trying to preserve albumin. And in that case, it can result in thrombotic complications. And lastly, the steroid complications. Okay. Lastly, it will be the steroid complications, of which we have already mentioned before. Okay. Now I want to talk about how do you manage. So how do you manage the nephrotic syndrome? We spoke about steroids, but how do you manage the edema? So you said edema is an important complication, and increasing edema can predispose to pleural effusion, and that can cause respiratory compromise. So how do you manage the edema?
Okay. So if it is severe and symptomatic, we have to hospitalize the patient. And if we have to check the albumin, and if it is less than 1.5, we have to albumin infusion has to be given. Otherwise,
I'll correct that statement. The answer is correct, but I'll correct the statement more. I'll modify that. Now, if the albumin is less than 1.5, or if the patient is presenting in shock, okay. If there is a patient who is presenting with shock and edema, you cannot give more fluid, correct? Because
Yes, sir.
so this commonly happens that the patient presents with shock, there is edema, and there is acute kidney injury or a reduced urine output. Okay. Now you can't pump fluids in this kind of patients because the more fluid you will give, the fluid will be retained in the third space, and it will cause a respiratory compromise. So in these cases, we have to give albumin. Okay. So the two indications to give albumin is if serum albumin is less than 1.5, and if the patient is presenting in shock and AKI. Okay.
Yes.
Okay. Then what else can you do?
We can give sodium restriction has to be there. Then if we can elevate the, I mean, in operative cases, we can elevate the foot and all. Then we can give furosemide can be given, but under watchful. We have to
Okay, so
watch.
I think I'll modify it because for want of time. So see, the thing is, we have a lot of medications that we can give as per guidelines for removing of edema. Okay. Now, we have two theories for causing of edema, and that the theory is too vast to explain. You can read behind it. It's not very complicated. One is the overfill theory and one is the underfill theory. Okay. Now, the overfill theory basically means there is more fluid. The underfill theory means there is less fluid. It has been proven in literature that most of the cases of nephrotic syndrome, there is more fluid in the body. So if there is more fluid in the body, you have to remove that fluid, right? Now, the removal of fluid can be done by the following medications. One is your furosemide. One is your thiazide diuretics. One is your spironolactone. And the last is albumin. Okay. We usually preserve albumin for the last because albumin is a costly medication. Okay. So usually what we give is we give Lasix. I mean, we give furopid. The furosemide at a dose of 1 to 3 mg per kg per day. This is provided there are no electrolyte disturbances. Okay, I'll tell you about the electrolyte disturbances after this. So if there are no electrolyte disturbances, we usually give furosemide at a dose of 1 to 3 or some books also say 1 to 4 mg per kg per day. We have a choice of giving a thiazide diuretic at 1 to 3 mg per kg per day. Am I audible?
Yes, sir.
Yeah, a thiazide diuretic at 1 to 3 mg per kg per day. And then lastly, you have your spironolactone. Okay. Now, spironolactone is a potassium sparing diuretic. So we cannot give it if the patient has got hyperkalemia.
Yes.
Okay. Right. We give albumin. There is one more reason why we give albumin that I didn't tell you because I wanted to add it on to this. Now, all these, if we also give albumin when the albumin is less than 1.5 for the major reason that if the albumin is very low, no matter how high the dose of diuretics you give, the diuretics cannot function because all these diuretics attach themselves to albumin and then go and act on the respective action of their tubules. So now you know that these different drugs like furosemide, the thiazide, all function at, they act on different sections of the tubule. So one acts on the loop, one action has an action on the ascending limb, one has an action on the collecting ducts or whatever. So wherever this medicine has to go and act, you need albumin to transport this medicine there. So if the albumin is already very low, no matter how high dose of medicine you give, the medicine will not function. So that is why in those cases where the albumin is extremely low, you have to give albumin. Okay. And the dose for albumin is 0.5 to 1 gram per kg per day. 0.5 to 1 gram per kg per day. We usually give it over a period of 6 to 8 hours.
Okay, sir.
Okay.
Okay, sir.
Right. The other thing to do is, and which you have not mentioned, is fluid restriction. Okay. Fluid restriction is very important. So the general dictum for fluid restriction is 400 ml per meter square per day. Okay. So again, I'm just giving an example. If this patient has got a meter square of 1, okay. Now 1 is the body surface area of a child who is roughly about 5 to 6 years of age. So if this, I'm giving it for example, for ease of calculation, the body surface area is 1. the calculation will be 400 ml per meter square per day plus the previous day's urine output. Okay, because this is a common question that is asked. How do you know how much fluid to restrict?
So can
Right?
you please repeat it one more time?
Yeah, I'll tell you again. This is confusing, so listen to me carefully. A common question is how do you restrict the fluids, right? So the formula is 400 ml per meter squared per day.
Per meter square
Per day plus the previous day's urine output.
Okay.
Got it? Now,
Okay, sir.
very often the child may come to you on the first day and you will not know the output. Right? So on that time, you assume it is 400 ml per meter squared alone. Okay?
Okay.
So if the meter squared is 1, that is, if the body surface area you are calculating is 1, or in this case you are calculated as 0.7 something. So it will be 400 ml into 0.7. Right?
Yes.
Which will be roughly about 350 or something like that. So that much ml of volume you can give to the child on that first day. The second day's calculation will be 400 ml per meter square per day plus the previous day's output. That means so you will have an output from the second day, no?
Yes, sir.
Yeah, so that day will give you the output that you can add on to the first day to give your intake instructions for the second day.
Okay.
And that will go on as the days progress. Okay.
Okay, sir.
Now, fluid restriction. This is fluid restriction. The second is salt restriction. Okay. Actually, there is no dictum about salt restriction in the diet for nephrotic syndrome. The rule is there should be no added salt. There should be no added salt. Okay. Salt restriction is advised only in cases where there is severe edema. That is important to note.
Okay, sir.
Okay. Because many of times, this is not like in adults. If we restrict sodium, the parents will stop giving sodium to the child and ultimately the child will have seizures because of hyponatremia.
Okay.
So if the child is not very edematous, what we usually tell parents is don't add any extra added salt. Okay.
Okay.
And the last thing to notice, if the patient is having a high potassium or if the patient is having an AKI, we ask to restrict the potassium containing food. So potassium containing food in our lands is basically banana, fruits, tender coconut water. So yeah, so these kind of things we ask to avoid or to reduce. So that is about diet. So I'll go to the last bit, which is vaccination. Okay. Now, what are the important rules for vaccination for these kind of children? Because vaccination advice is a part of advice that you must give the children before they leave your care, right? So what is the advice about vaccines?
We shouldn't give live vaccines during until the prednisolone is less than 1 milligram per kilogram per day or 2 milligram per kilogram on alternate days. And it is also, live vaccine is also contraindicated in those children who are receiving steroid sparing agents like cyclophosphamide and cyclosporin. And we have to give annual influenza vaccine as well as pneumococcal vaccine.
Yeah. So pneumococcal vaccine is important to remember. In our country, even in our state, we usually initially used to provide PCV7. Okay, PCV7, which improved to PCV10. The guidelines say that even if the child has received PCV7 or PCV10 before, you must offer the chance to give them PCV13. And then after giving them PCV13, you must give them the option of giving PCV23. Okay, that is the full vaccine. Okay, because this is a special case. So the child should receive yearly the yearly influenza vaccine. And along with that, PCV13 and PCV23 must be given. And PCV23 is not a single dose. There is a booster dose for PCV23 after 5 years. Previously, people used to say that if the child, you can take live vaccines after stopping steroids within a period of 12 weeks. Okay. The guidelines which you just now stated, it's in a case of emergency. Now you have, for example, a case where there is a measles outbreak and you have to give the vaccine to a child. In that case, you can wait until so far you reduce the dose to how you said, an alternate day regimen, and then plan to give the live vaccine. But otherwise, it is best to avoid giving live vaccines unless you stop steroids for a period of 12 weeks. Okay. Now, what if the child has got varicella during this time? You're giving steroids and the child has got varicella.
Close contact with varicella infection, we can give immunoglobulins.
So the child, because you have to treat as a normal varicella infection, plus you have to give immunoglobulin also. This is very important because varicella is one of the most important complications. I also want to tell you that while we talk about live vaccine, it is very important to advise people from our country not to give your annual follow-up the OPV vaccines, because very often they come from Anganwadis and they say give the OPV vaccine, and that's a live oral vaccine. I've had cases where even including for nursing people, that is nursing staff's children who've got oral polio, who've got polio after being administered oral polio vaccine when they were on steroids. So this is also very important to note. So I think I've covered most of the things, clinical features, the presentation, classification, how do you manage, what are the common complications, and regarding vaccines, and fluids, regarding fluid and diet. If there is anything to ask, you can ask. Yeah.
Sir, is there any diet for this nephrotic syndrome?
So diet is roughly like this. No added salt in the diet. That is no added salt. No added salt means no extra salt. Extra salt comes from your noodles, bread, chips, your bakery items, and all these things. So there should be no added salt, but you can give your regular salt diet. Salt restriction is only indicated if the child has got severe edema. Fluid restriction as per what I told you, as per the guidelines. And everybody is always confused about the protein in the diet. So they can have regular protein in the diet. There is no need for adding extra protein, okay? Because so people will believe that if you give extra protein, the condition will go, but that's not the thing. Because so long as the child is already passing urine, and in that urine there is albumin, the more protein you give, all that protein is going to be lost in urine. So there is no need for any added extra protein as per the recommended daily allowance only.
Sir, we have to restrict the water only during the relapse phase. No, on the other remission phase.
Yeah. In the remission phase, good question. In the remission phase, there is no fluid restriction. Yeah. Now, I forgot to mention an important thing. What are the requirements? What are the needs to do when to do a kidney biopsy? Okay. So this I'll tell you. The indications to do a kidney biopsy. I told you initially itself. There are some atypical features of presentation, right? Yeah. So atypical features means if the child presents with, you can write this down, gross hematuria. Gross hematuria is 1. If the child presents with hypertension at the onset of symptoms itself, the child has got hypertension. Okay. If the age of presentation is less than 1 year or more than 12 years, some books say 10 years, but you can refer what your textbook tells you. But we broadly say less than 1 year or more than 12 years. Hello?
Yes, sir.
And if there is AKI at presentation, that is, if my nephrotic syndrome is presenting with an AKI, but bear in mind, this AKI must not be able to be explained by a pre-renal etiology. That means if the patient is presenting in shock, and as part of that shock has got an acute kidney injury, that does not mean an indication for biopsy. If the patient does not have any other explainable causes for AKI at time of presentation, then that is an indication for biopsy. And lastly, if you are planning to start any steroid sparing agent like a calcineurin inhibitor, that is any medicine like a cyclosporin or tacrolimus, then you have to do a biopsy.
Okay, sir.
Yeah.
Sorry, if a patient comes to the family physician who is on the steroids and all, what are the investigations we have to do routinely? And in case of
so this is important. Okay. Now a patient in nephrotic syndrome is coming to you. He's already on steroids. This is important for you to know, so I'll tell you. Now this is very common presentation. A child who's receiving high dose steroids, and suddenly the child has got fever. Okay. Child has got fever, a fever of 2 to 3 days duration. You have no focus, and they're coming to you and asking you for advice. So what do you want to do?
So I think initially we have to check the basic lines like CBC. Then we have to go for urine PC ratio.
You will do your CBC. You will do your urine exam. You will do your urine PC ratio. The most important thing to do under these conditions is to bring the dose of steroids down to a stress dose steroids. Okay. A stress dose steroids means less than 0.5 to 1 mg per kg per day. That means, for example, if the child is 20 kgs, I would want to bring down the dose of steroids to less than 1 milligram per kg per day. that is less than 20 milligram. Let's say 15 milligram I would choose. This is because in these kind of patients, while the patient is on steroids, a lot of clinical manifestations of infections may be masked. So we cannot stop steroids because of that, because if you suddenly stop steroids on a patient who is already receiving high dose steroids, you can predispose the patient to an adrenal crisis. Okay. And an adrenal crisis will present with hyponatremia, hyperkalemia, and an AKI. So because of that, we cannot stop the steroids, but we should come down on the dose of steroids until the duration of stress is over. That stress is the duration of fever. That duration is usually about 3 to 5 days. Once the fever settles and we treat it accordingly. I forgot to tell you an important complication, peritonitis. Okay, that is a very important complication. So,
bacterial peritonitis.
peritonitis.
Bacterial peritonitis.
Peritonitis, correct. Yeah. So in these conditions, for example, if we are suspecting a bacterial peritonitis, let's say our child is presenting with fever, loose stools, or sometimes they may not even present with fever because they're already on high dose steroids. So if you have a doubt, we'll send a blood culture, we will send a stool culture, we will start antibiotics, and we'll bring down the dose of steroids to a stress dose. Once the culture is negative and once everything else is negative, we will bring back to the old dose. Another thing which I did not tell you is how to treat a relapse. This is also very common. So you might get a patient who is previously steroid sensitive. You treated, or somebody has treated, and the patient has got full dose steroids, became negative. Now, 6 months later, the patient is presenting with a relapse. So at that time, what you should do is, now you will know, the investigations by now, what to do. You will do a urine PC ratio, you will do a urine routine, you will do a creat, you will do electrolytes, you will do your serum albumin and cholesterol. Important thing to do is starting the patient on full dose steroids. Hello?
Yes, sir.
Yeah, the protocol is to treat the patient with full dose steroids until the patient attains remission. For most patients, that is between 5 to 7 days. So give full dose steroids till the patient attains remission and then taper. Okay. And then bring down the dose by 5 milligram as per this one. Because you don't have to treat a relapse like how you treat the first episode. You can treat a relapse like how you treat until the patient attains remission, and then you slowly taper the dose of steroids.
Okay, so it is like this, no? First of all, if the patient comes with to us with an infection or fever, first we have to do is to reduce steroids into stress dose, and after infection settles, we have to again do the investigations like CBC, URE, urine PC ratio, and all. And if it is showing abnormalities, then we have to take it as a relapse, and then we have to start steroids.
Yeah, we have to start steroids. But if it is a relapse because of a peritonitis, you have to treat the infection first before treating the nephrotic syndrome. So you will have to keep the patient on stress dose steroid, treat the infection with antibiotics. Once the infection clears, then you bring the patient back to full dose steroids. I saw a question by one of the students. So it was asked about ruling out TB. So I thought it was already known. That is why I did not mention it. So among the investigations that you have to send first time when you are starting steroids is you have to rule out TB. So in our country, previously the guidelines was to do a TB, was to do a MAN2 and a chest X-ray. Now, because the facilities are more available, we also do a MAN2 chest X-ray. We do a TB Gold as well. But we do not wait for the report of TB Gold. TB Gold report usually takes about 5 days. So we start the dose of steroids if there is no contact history, and then we evaluate the report. Somebody
have also asked about repeating information about vaccines, varicella.
See, varicella, if the patient is on full dose steroids, and if the patient has been exposed to a contact or a child who's got varicella, that the child who's on steroids must receive the treatment for varicella with acyclovir as per the guidelines. Plus, they should also receive the immunoglobulin. That is, they should receive both. If it is usually you are exposed, you will only need acyclovir, right? But in a patient who is on steroids, if the patient is exposed to varicella, you will also need immunoglobulin. Yeah. Somebody asked me a question about renal transplantation, but that is a very difficult question because a renal transplantation is usually indicated for patients who are having congenital nephrotic syndromes or infantile nephrotic syndromes, or with genetic variations of nephrotic syndromes. Our normal nephrotic syndromes usually never require genetic transplantation. We have a form of nephrotic syndrome called monogenic forms. That is, they are mostly genetic forms. Your genetic forms of nephrotic syndrome, like there are many mutations: WT1 mutation, PLC1 mutation, a lot of mutations, infron mutation, INF. These are kind of LAM2 mutation. These are mutations that may require renal transplantation, but that is a very long topic. And that is not usually up to, I mean, for this one, because it is mostly, almost all of them will be usually steroid resistant. And you will have to anyway refer them to a higher center for further management.
Yes.
So, role of rituximab?
So, rituximab is a steroid sparing agent. So that's also a long topic. So steroid sparing agents, we have 4 to 5 alternatives. So one is levamisole, which is a mild antihelminthic, but that is not for use. That is only for use in patients who are frequent relapsing nephrotic syndromes. You have a cyclophosphamide, oral cyclophosphamide, which is useful again in frequent relapsing nephrotic syndromes or steroid dependent nephrotic syndromes. You have mycophenolate mofetil, also useful for steroid dependent nephrotic syndromes. And lastly, your class of drugs called calcineurin inhibitors or CNI. So that is your tacrolimus and cyclosporin. Among beyond after all this is the last option in pediatrics, which we call as rituximab. Rituximab is an anti-CD20 monoclonal antibody. The use of it stems from the fact that there is a belief that the nephrotic syndrome is caused because of alterations in B cell and T cell involvement. So because of that, the use of rituximab is increased. But the problem with rituximab is its dose or regimen, nothing has been established in the world. We usually give it for steroid dependent and steroid resistant nephrotic syndromes. The generalized, widely accepted guidelines are 2 doses of rituximab, 2 weeks apart. 2 doses, 2 weeks gap for patients who are having steroid dependent nephrotic syndrome, and 4 doses, 4 weekly doses, week apart for steroid resistant nephrotic syndromes. But again, the follow-up dose, how to follow up the dose of rituximab is not established. So different books will give different opinions on this matter. Some people will give 6 months rituximab. Some people will wait and see if there is any further relapses. There are also people who will give initial dose of Ritux and then will lower the immunosuppressant to a tacrolimus or an MMF and wait for response. But that is very difficult to talk about in this short period of time. That is because that is a wholly different topic.
Okay, sir.
So there
Sir,
is
just a doubt.
one question
Just one more
to
doubt.
ask.
Suppose the mother asks, will my second child also get nephrotic syndrome? What should be the answer? What should a family physician say?
Usually if the patient has no other family history, and if there is no other atypical features at presentation, and there is the onset of symptoms is after 1.5 years of age, there is nothing atypical. The chances of a child of another sibling having the same condition is extremely rare. But I have had conditions where very rare cases where there is a child of mine who's got nephrotic syndrome, and his father also had got nephrotic syndrome in childhood, and both of them continue to relapse. The father was in his 30s; he continued to have a relapse a year. The child was also having relapses, but the other children did not have relapse. So it depends on family history. I think it is safe to say that if there is no family history and if there are no atypical features, the chances of a sibling getting nephrotic syndrome is very unlikely.
Thank you, sir. Thank you.
Yeah.
Okay, sir. So
There is
I
a
think
question to just repeat about the PCV vaccine administration, the chat box.
See, PCV, what we do is we administer the vaccine. Ideally, they should get the vaccine as per schedule, and they should get additional doses of PCV 23. Simply put, okay, if you put simply, they should get additional. If you have already got the PCV vaccine as per schedule, they should get PCV 23 and fill up the boost and finish off the schedule. If you've not already got the vaccine, you should get, no matter whether you've got PCV 7 or PCV 10, you should get a booster of PCV 13 and then go on to get PCV 23 and the booster for PCV 23. Hello?
Yes, sir. So
Yeah.
there is a question about use of steroids in case of tuberculosis.
See, that is a very difficult topic, because what we usually do is we focus when the question becomes whether the patient is TB positive and between the patient who is nephrotic syndrome positive. What we usually do is we initiate TB treatment and we wait for 2 weeks. until when we start for steroids. We usually start TB first. It's like how you treat for your hepatitis. Hepatitis and TB. We start treatment for TB first, give it a period of 2 weeks, and then we start the treatment for nephrotic syndrome. During that time, if the child is edematous, we approach to treat the edema with albumin infusions and with diuretics. Yeah, the TB treatment, but should start first because that is more damaging. Yeah.
So there is no need of completion of TB treatment. No? That is 6
No,
months.
we can't wait. We can't wait. We can give a period of 2 weeks before we start steroids. Yeah. Although I've discussed the same question with the infectious disease team from our hospital, and they say there is no harm in starting steroids. But what we used to do in our practice in Vellore, for example, in CMC, was we used to wait for 2 weeks. As far as I know, there are no established guidelines regarding this. You will not be asked a question, but there is no harm in saying that the priority would be to treat the TB first and then this nephrotic syndrome. Yeah. Is that all?
So we have answered all the questions, I suppose. Now, thank you, sir. I would like to invite Dr. Indu Rajiv, President of FPI Kerala Chapter, to deliver the concluding remarks.
Good evening, all. Thank you, Dr. Vishnu, for giving me the chance to say the concluding remarks. It was indeed a wonderful academic feast, environment for learning and exchange. Well done, Dr. Bismita, for selecting a challenging pediatric case with nephrotic syndrome. I think 1 hour is not at all enough for the discussion. I know that, but let us have it another time. Thank you, Dr. Prajo and Dr. Aishwarya, for accepting the invitation and for moderating the session in spite of your tight schedules and sharing your expertise with us today. And it indeed facilitated a productive and engaging conversation, and you truly added value to the session, and the comments, questions added depth to the discussion. And Dr. Prajo, special thanks to you for you ensured the discussion stayed on track and it was very productive. I think most of our PTs enjoyed that. And thank you once again. And I think we have come to the end of the session. Over to you, Dr. Vishnu.
So thank you all for joining for this session, and we hope to have more sessions in future. Thank you all. Good night.
Good night.
Good night.